Yeah,
It's starting from resting to each eye. Is that
maybe asepsis too.
asepsis?
I think so.
To the eye?
For the eyes, I think so. I'll check the test and I'll
Thank
let
you.
you know, okay?
Thank you. Because it would be better.
Okay. We'll begin now. So we're going to be reviewing parenteral medications for today. So when we're giving, we're beginning. When we're giving medications, we have different routes we had went over for administered medication, right? This route, we're going to use alcohol swabs, whichever vial the medications are in. Sometimes we'll have a mixed a vial, or we have to mix it ourselves, okay? We have to make sure we know the specific route where we're going to administer the medication, which we did over a lecture, you know, sub-Qs, IMs, we have different areas, and we always want to make sure that we rotate, okay? We want to know the amount of the medication that you have to administer, and that is all you would see in your doctor's orders, okay? So it's not a guessing game, so please don't assume, please don't guess, please don't watch what your colleague is doing. You know, you do the right thing, you follow the orders, and make sure that your patient is safe at all times. Okay? These type of medications can also vary on body size of the patient, what you learn in Med-Cal, right? You always have to consider the patient's weight, height, male, female, things of that sort, okay? So best make sure, you know, just the best know how much of the medication the patient is getting and the treatment, that they're getting the accurate treatment, okay? If there is a need for something called a filtered needle, which most of the times you do need a filtered needle, unless you're mixing a medication, you can use something called a blunt needle to draw up a saline to mix the medication. Always be mindful of that, okay? So this is what your syringe will look like. It has the plunger on top. This is where you'll push, all right? You have your barrel here. This is where you'll detect the amount of medication that's needed to give to the patient, okay? Your threads are a little lock right here. So be mindful when you go inside. When you're pulling up your medication, you're gonna see like a little U shape. It's gonna look like so. Oh, a little bit nicer. This is how your medication is gonna look inside of the barrel. Okay? So just know that this area here, this is gonna be lost medication. So try not to give the patient less than what is needed. So once you drop your medication, if you need 1, 2, 3, 4, 5 mLs, it's gonna be like this, 2 and 1, right? You're gonna drop a little bit more than, okay? You're gonna turn your syringe upside down, and then you're gonna push out the little bit of air that is on front. I'm not saying to push out medication, I'm saying to push out air, okay? Just so you have the accurate amount of medication that you're giving to your patient. Understand? You have your hub, your needle hub, the safety guard. This is when you are finished injecting your patient. Not with your hands, you're not gonna close it. You're gonna put it against either the table or something to clasp the safety guard and the needle together. Okay? Please do not use your hands, because then you're risking yourself for a needle puncture. Alright? You'll see closely when you get inside the needle, it has a bevel. Okay? This is how the medication is being administered. Alright? And this is the shaft of the needle. Administration of the medication. Subcutaneous injection, it goes into the subcutaneous tissue. Intramuscular injection, it goes into the muscle tissue. Intradermal injection, it goes right underneath the epidermis area, okay? And the intravenous injection, it goes into the what?
Vein.
The vein, exactly. So you see this is supposed to be the skin area here, and this is how it's broken down. We have the epidermis, second layer is the
Dermis.
third,
Subcutaneous tissue.
and then the last,
Muscle.
exactly. And this breakdown, you have it on your PowerPoints. It also reminds you on how you're supposed to be injecting in each area. All right, so always intramuscular is what degree angle? 90?
90 degrees.
Okay, intradermal is
15.
10 to 15.
10.
Okay, intravenous? 25. Got it? And then the sub-Q?
45.
Excellent. Okay, so when you're preparing your medication, you have your what? Ampules,
Vial.
vial, and your
Pre-filled syringe.
pre-fill syringe, okay? You can also get medications such as, blood thinner, and it's always pre-filled, okay? Or, narcotics, it's always pre-filled. Okay, so these are the different sites for an intramuscular injection. Please notate these sites because you have to rotate, right? Okay? You're gonna have your favorite sites, but there are some medications that has a preferred site because of it might cause some pain to the patient. Okay, so if you're giving something like tramadol, which is a pain medication, it's a narcotic as well. It's normally given in the emergency room if a patient comes with a lot of pain, lower back pain, leg pain, some type of traumatic injury. They're gonna give that tramadol where?
Maybe the deltoid. Not
You
really.
can,
Maybe the vessels lateralis.
not bad.
Because it's
Uh-huh.
has a lot of.
But if you want somewhere that's a lot of muscles, what do you think?
Ventral. Really? The back?
This is not the back.
It says
This is
dorsal.
the side.
Oh,
This is the
oh.
buttocks.
Oh, that's what I
Yeah.
meant when I said
So-
ventral. I thought that was the one. So what is the last one?
So,
No longer.
which last one?
The ventral.
gluteal?
Yeah.
You have a dorsal gluteal and then you have the ventral. So the ventral is on the side,
Right. And
The
this is.
dorsal
Oh,
is
okay,
next to
okay,
the
okay.
okay? So medications that are more higher in volume, for instance,
Which one?
you, I'm sorry?
Use it no longer, this side.
Dorsal gluten side.
For
is
your exam,
Yeah.
yes, you do not use it any longer. When you're practicing, you'll learn the difference, okay? Because if you've ever had a medication with a larger volume, that's a narcotic, and you need it for pain,
Right.
this is where your preferred site is gonna be, okay? You always wanna be the patient's advocate, okay? I mean, you don't wanna wait till you go through something to say, oh yeah, so that's what Mr. John felt last week. You know what I'm saying?
Yeah.
So it's a larger volume, a bigger needle. You're gonna want to pinch, give the patient the medication, and they'll feel a bit more relief, okay? So always keep in the back of your mind, there is your textbook world, and there is the real world.
Real world.
Okay?
What do you recommend in exam?
It's probably safety measures, but you know, everything changed based on what?
What's going on in the world?
Yeah. Since
No,
COVID, like a
based
lot
on
of
studies. It's called
studies,
evidence-based
study.
practice,
Yeah.
you know?
Yeah.
You
Yes,
have
it's like some
evidence-based
medication
practice
that out
that
there for
determines
20 years
rules
and they
and
tell you it's no
regulations.
safer.
But if you're working on a day-to-day with your patient, you'll kind of get a idea of what works for them and what does not work. Okay? It's not recommended, it doesn't say it's not in use any longer, it just says it's not recommended. Okay? Vaccines, where do we give vaccines?
The deltoid.
Delta. Okay. For babies, if you're giving vaccines, where do we give vaccines?
The vascular lateralis.
Perfect. Okay, so there's always preferred sites. Just keep them in the back of your mind. So when you're giving an IM injection, there's something called a Z-track technique. So can anybody read what the Z-track technique is?
When you pull back the skin.
Not really pull it back.
Just
You kind of
maneuver it.
separate it in a Z type of motion. You wanna read for me?
Attach a clean needle to the syringe after withdrawing the medication from the vial or ampoule to prevent any residual medication that may be on the needle from being injected into the superficial tissue. Displace the tissue down or to one side by pulling the skin approximately 1 to 2.5 centimeters to the side. Inject the medication slowly, approximately 10 seconds ml. Once the medication has been instilled, wait approximately 10 seconds before withdrawing the needle. After the needle is withdrawn, a seal is formed over the site, and this helps to prevent seepage
Yeah. I
of
think
medication into the subcutaneous tissues and subsequent discomfort. Apply gentle pressure to the site with a dry gauze. Do not massage.
Okay, same thing like what Dr. Colombo said earlier. Back in the days, we used to massage, like, oh yeah, get it in, get it in, get it in. No. Evidence-based practice has shown us that it is not adequate to massage once you give an intramuscular injection. Okay? So Z-track, you see how the finger is, you're taking it, you're actually spreading like the skin. You know, you're trying to spread the fatty area thin so you can get directly to the muscular area. Okay, so that's the goal. Alright, so keep that in mind. Alright, so subcutaneous injection. So you're administered into the adipose tissue layer just below the epidermis and the dermis. So you remember a couple slides back when we were looking at the different
Yeah, the angles.
layers of the skin? So this is what it's referring to. Okay? So what are the various sites that are used? First one is
Outer aspect of the arm.
okay. Second?
Abdomen.
Okay. And where's the abdomen?
It's above the umbilical cord.
Okay. Alright. The third one?
Anterior aspect of the thigh.
Okay. You see where it is? It
Yeah.
also goes a little bit towards the side too. But make sure you feel
This is for
more muscles.
subcutaneous?
Yeah, subcutaneous. Like if you're giving pepper
Oh, okay.
or so.
Insulin too.
Insulin? The fourth one?
The upper back.
I have never seen this happen,
Yeah. No.
but it's an option. Okay. And the last one?
Upper ventral or
Dorsal
dorsal
Okay.
Ooh, that, I think it's painful there.
No?
No? The
It's
bone
less
is like,
painful. No. Remember, you're not going to bone, you're going to
no,
muscle.
just,
Okay, so we're not talking about the.
right.
What are we not talking about?
I'm sorry?
You mentioned it earlier. We're not talking about the what? The back.
The back, right,
We're
yeah.
talking about the glutes. Okay?
Dermis.
Intradermal injection. Go ahead.
Me? Administered into the dermis just below the epidermis. Has the longest absorption time of all parenteral routes. Used for sensitivity tests and local anesthesia. Body's reaction to the substances is easily visible. Sites commonly used are the inner surface of the forearm and the upper back, under the scapula. What is it? A fourth to half. 25 or 27 gauge needle is gauge. Needle is used, and the angle of administration is 5 to 15 degrees. The dosage given intradermally is small, usually less than 0.5 millimeter.
Okay. Has anybody ever gotten a TB test?
Yeah,
Yeah,
I had this
TB
before.
test planted, a PPD they call it too.
Yeah.
Yeah. So that's what it is.
I had also allergy done like this way.
The allergy test.
Yeah.
Because
Okay.
it hurts.
Huh?
It hurts.
It hurts.
Yes,
Yeah,
of
it's
course.
actually
Anything
very
is going in your
superficial,
body.
So it hurts. Yeah, it's very
Yeah.
sensitive.
Yeah.
Even just going like this to your inner forearm, it's a little sensitive.
Right.
Yeah, that area is sensitive, so it does hurt. But not like you're putting a 10 cc medication
Right.
it will hurt more. So that's why there's preferred sites. But this site here, for instance, a TB test is the only site you can use.
So they're no longer doing these kind of tests for TB, cause I think she said they're doing only the
Quantiferin?
quantiferin.
Yeah,
So
they
you're no
still
longer doing
do
this?
these tests.
Okay.
But more and more facilities are now understanding and accepting that quantiferin is more accurate.
Okay.
Yeah.
They do it on residents, so every time there's a new resident, they do it automatically. And I asked, I was like,
Say that again, I'm sorry.
we did it on residents, like, so they do that. And I asked, like, they don't do it anymore, just like, oh, like, the facility, they
Thank
do
you.
it to every single resident that comes in.
Maybe for others.
You mean for the
they're doing
PPD
TB.
test?
Yeah.
Yeah, so facilities are still using it. But it will be nicer if you get the quantiferin. Quantiferin is more accurate.
Right, but I was saying like hospitals are using it, or?
Anybody, yeah. It's not a worldwide or statewide
I never
thing where
got
all
that,
hospitals
so-
don't, but nursing homes do. No. It's up to the facility policy. So everybody's good on intradermal injections? You have an idea on what it is?
Yeah.
Okay. So intravenous administration of medication.
Send it to me yesterday.
Can you read this for me, please?
Me?
Yeah.
Again. Oh, her or me? Oh, you.
Yeah.
You.
Let's go. Delivers.
Delivers the drug directly into the bloodstream.
Again.
Delivers the drug directly into the
You
bloodstream.
hear that?
Yes.
Okay.
Medication has an immediate effect and cannot be recalled or action slowed. Can't take it back.
Can't
That's
take it. Thank you. You cannot take it back.
Route most often used in emergency situations.
Correct. So you see how intense the intravenous administration of medication is?
Yes.
Once you
Into
go,
the vein.
there's no coming back.
Mm-hmm.
So you have to do all your
Check.
checks before you administer that drug to the patient.
So this you're gonna have to pull back to see if whoever come out, and then you have to.
Absolutely not.
Yeah.
So
What? What is it?
I said absolutely not.
Oh, you don't have to see if it's in the.
She
Just
said
say
you have
check
to
it.
pull up all
You're
the-
talking about if you're planting an IV,
Okay.
correct?
Yeah.
You wanna see if you have an
Isn't that
accurate or
bloodstream
potent IV access?
Yes.
Yeah.
That's what you're saying?
I mean, isn't it in the bloodstream? Is it saying?
Is what in the
I'm
bloodstream?
saying the intravenous is in the bloodstream, right?
No, it's in your vein.
I'm saying it's in your vein.
It's in your vein. No, you said if it's in your bloodstream.
Your vein.
So I want you guys to, I tell this to my clinical group all the time. I want you guys to know what you're talking about, be assertive, so that when you're speaking, people are gonna respect you for what you're saying because you know what you're talking about. Okay? So your bloodstream and being in the IV is two different things. Your bloodstream is something going on in your body. That's your bloodstream. You can't see it. It's already going.
Right.
Okay? Your vein is where we put an IV catheter in so that you can receive medication, mostly medication. Okay? Even if it's an IV bag, it's medication. Normal saline, it has something in it, it's medication. Right? So, this IV is in his vein or her vein, and this person, provider, nurse, doctor, PA, nurse practitioner, whoever, is administering whatever medication into this patient's vein to go into their what? Bloodstream. Yeah?
No, I think what she meant is,
No,
and I
we
also want to
already-
get that
We already
point.
spoke about what you meant.
Yeah, but I also want to understand that part. Do we have each time we give a medication to, to pull and see if the blood is coming back and make
To see if
sure
it's
that it's
working.
to make sure it is inserted in the right place.
Yes.
No.
Why not?
We don't have to do
When
that all
have
the
you
time.
ever heard you're supposed to pull back on medication being administered?
It's not medication.
administered
Not
to
medication, the
see-
blood, to see if the blood is.
When did you hear that? Was that taught?
This morning, Professor mentioned it. I don't know, maybe when it comes. And I think Professor Colombo did mention this
She
morning.
said something about it.
Yeah, she
so
did say
that's
something
why I
about
asked her.
what is it? The medical word. Yeah.
Is it aspirin?
No, not aspirin.
flush
It
it?
could be aspirate.
It's like the
Yeah.
flush it.
Is it like when you put back?
I think they're saying like you wanna see if it's working, they try to see if there's blood
Okay.
coming out.
So there are ways
Oh
to
yeah,
go
we did
about
mention.
it.
I tell you when we say you have to make sure so that, so for example, there are some signs that tells you that the medication
Yeah,
or
yeah.
the IV is not going in the
Mhm.
vein, swollen and stuff like that.
Correct?
So given the medication, each time you want to give the medication, do we have to make sure we drink?
No, no. What you can do, a safe way you can accurately see if your IV line is potent,
Right.
meaning it's clear,
And in
it's
the
not
vein.
blocked, free
won't
from
get
any
in-
debris, so
it'll
that
get-
my medication can go in. You can test the line with something called normal saline.
Yes, yes.
Okay.
Normal saline, yeah.
You can get normal saline, just a small amount,
Yes.
and you can push. You do like a push pause method. And see if that normal saline goes through freely, or if it doesn't, it's blocked. Then you can manipulate this
Okay,
line,
okay.
okay? But there's no reason why you should be aspirating when you're giving medication, any blood,
Right.
to see if that line. Imagine if someone did that all the time. What do you think that patient is at risk for?
Blood loss? Is it blood
Infection.
loss? Or is,
No.
Infection?
Blood
Can it be
loss.
infection?
Infection. So if I came on my shift,
Mhm.
7 a.m., to check if this is, and I'm checking, pulling back and pushing in.
No.
And you come on your 3
That's
o'clock
what you're
shift,
asking, pull it
you're
back and
pulling
push
back
it in.
and pushing in,
No,
and
I
you
know
come
that
on your
put
11
the
o'clock
saline
shift, and
in
you
and
pull it up.
push it up. You
Are you
gotta
gonna-
back out.
Because my
You
dad was
understand what
getting
I'm saying?
chemo and they were all the time doing that to him.
This is different.
That's why I was
Chemo
asking.
has a what? A port. Okay? Ports should be always open. If there's a blockage, there's ways you can reduce that blockage or clear that port. Okay? So what they're pulling and pushing, it could be normal saline,
Right.
but there's no medication.
Not a
There's
medication,
no
no.
pull of blood and push
Mhm.
it back in
Yeah,
blood.
that was like.
Yeah. So I want you guys to understand that because that is a risk for what?
Yeah,
Infection.
because even if you can't get it in, you wouldn't be there poking the person how many times
Not
trying
poking,
to
no,
do
no,
that.
no, it's already in.
I have a
Just
question.
using the extra
Can you
syringe. No,
do
not
blood
poking.
from the IV or you have to find manual?
You're not supposed to.
But they do.
You're not supposed to. It's not written in like your book or a standard of care. No, no, no.
You have to really.
If the patient has a line, like a central line, yes.
Can I?
Patient has a central line and there's 3 lines to it. There's one you can get blood from. There's one you can do only a certain type of medication, and there's another one that's free for maybe a continuation of medication.
And that would be here. That would be really on.
It can be any central line mean it could be in your jugular, it could be anywhere, central lines are accepted.
I have a question. So, why don't they choose the obvious one, like sometimes you see blue one? So they look for another vein. Why?
Why do they?
They don't choose, like sometimes you see here, like I see here like a blue one. So why don't they choose it? They look for a different one.
It's
So it
inconvenient for the
depends, so the goal when you're in the hospital, if the patient's in a hospital, or a patient's in I would say hospital, the goal is to find a line or an area where you can put an IV line in, that you don't have to take it out,
Take
or
it
find
out.
another
Because
IV line in
sometimes
to
it's so
administer
thin.
any
Yeah.
type of medication or blood or
Yes.
anything like that. The goal is to put a 20 gauge in.
Mhm.
Okay, a 20 gauge is a large borehole needle line that can also administer blood through.
Yes.
Okay, so that's the goal. Because if you get anything smaller,
Mhm.
you're gonna have to put another one in to the patient so that
You don't
patient can
wanna-
get a blood
right.
transfusion if needed. So the goal is to put in a 20 gauge line
So it can be used for everything.
so it can be used for everything.
Anything,
So
yeah.
that's, you as the nurse, you're gonna wanna advocate your patient,
Right.
yeah? And you're gonna wanna put in that 20 gauge line. It may
Yes.
hurt, but at least you know you're hurting the patient at one time.
One.
So I want you guys to start thinking along those lines, The patient's concern is pain. Your concern is how can I limit infection? How can I give my medication? How can I make sure my patient is safe? How can I advocate for my patient? You got a lot on your plate.
Right,
But the patient is thinking, I just don't want to be in pain.
right. Can you use the smallest one? That's what I do all the time. Can you use the smallest one?
So that's the goal.
And this after you put in the medication, you push
You're gonna
say-
flush.
Yeah, flush.
Yeah, you're gonna
You're gonna
flush
flush
the
that.
medication slowly, not fast, okay? That's the goal, alright? Because you also don't wanna blow your IV line.
Oh, you mean like just do it so fast that it goes like pops out?
Huh?
You mean like doing it so fast that the needle pop out? You said not blow it.
Yeah, that's what I mean. When I say blow it, I mean, you can actually blow the vein where it's no longer potent. It pops, breaks. You have to find another, line, IV.
My doctor usually he draws blood first and then puts the iron in the same.
Correct, that's the correct way to do it. Mhm. So if you're gonna get blood and you need to put a patient's line in, you're gonna wanna draw the blood first from that IV, this part. Just this part. And then once you're done with the blood, you can connect. And then you can clear the line. All right? Testing blood glucose. Who can read this for me? Testing blood glucose.
Blood glucose testing is performed to assess the patient's glucose level as a measure in the management of diabetes. There are various blood glucose testing monitors. The following information applies to one specific unit and is referenced as a sample of this skill. How to mix and inject insulin with a syringe.
Okay. Let's see if this works for us.
I started with Logan because my last duty assignment in the Army was at Fort Leonard Wood, which is also in Missouri. And the chiropractor
We're not gonna watch the whole 9 minutes.
Proper insulin injection technique is critical to managing your diabetes. Whether you're new to injecting insulin or just want a refresher, I think you'll find this video demonstration will make you more comfortable with the process. I'm going to cover the basics of how to mix and inject insulin with a syringe, but if your doctor has suggested a different method, always follow your doctor's instructions. For this demonstration, I'll be using a 0.5 milliliter BD insulin syringe with the BD ultrafine 6mm needle. And I'll be mixing 2 different U100 insulins, 23 units of cloudy insulin and 10 units of clear insulin, for a total dose of 33 units. This is only an example, so be sure to check with your doctor to determine the syringe and the dose that are right for you. First, gather all your supplies onto a flat surface. You'll need your syringe, the bottles of clear and cloudy insulin, 2 alcohol swabs, and a sharps container. After washing your hands with soap and water, open the alcohol swabs and place them on top of the packages. Before I continue, I want to make sure you're familiar with the parts of the syringe. The largest part, called the barrel, has markings that are used to measure your insulin. A 0.5 milliliter barrel can hold up to 50 units. The long lines mark every 5 units, and the shorter lines in between indicate single units. The barrel has wings, or flanges, on the bottom to help you hold the syringe. A white cap covers the end of the plunger. Inside the barrel, the plunger has a black rubber stopper that moves as you push or pull the plunger. At the other end of the syringe is the needle, which is covered by an orange cap. Make sure your syringe has an orange cap and that the barrel is printed with U100 only. If your syringe doesn't have these features, it's not designed for insulin. Unless your doctor tells you otherwise, only use an insulin syringe. Next, let's look at our insulin bottle. If you're using a new bottle of insulin, remove the bottle's plastic cap and throw it away. On the insulin label, write the date you opened the bottle. That way you'll know when a month has gone by and it's time to dispose of the insulin. Before injecting, always check both bottles of insulin closely. If they have any lumps or crystals or a strange color, dispose of the insulin and use a new bottle. If you have any questions about the way it looks, check with your pharmacist. If the cloudy insulin looks okay, gently roll the bottle between your hands about 20 times until the liquid is well mixed and has an even look. Be sure never to shake your insulin. That could create air bubbles or even damage it. And there's no need to roll the clear insulin. Next, use one of the alcohol swabs to wipe the top of both bottles. Then let the alcohol air dry. Now, when you mix insulin, the first step is to inject air into each bottle equal to the amount of insulin that you intend to take from each bottle. This makes it easier to get insulin into the syringe. To get started, twist and remove the white cap from the end of the plunger. Then, pull the orange cap off the needle, making sure to pull straight off to avoid damaging the needle. In this example, my dose is 33 units, made up of 23 units of cloudy insulin, mixed with 10 units of clear insulin. Always put air into the cloudy insulin first. So to get 23 units of air into the cloudy insulin bottle, first, I need to get 23 units of air into the barrel of the syringe. To do this, simply pull the plunger until the end of the rubber stopper closest to the needle goes past the 20 unit mark to the third small line. This is the 23 unit mark. Now, hold the syringe like a pencil with your dominant hand and hold the insulin bottle on a flat surface with your other hand. Place the needle's point directly above the center of the bottle's rubber
See
top,
the angle?
being careful not to touch the metal rim with the tip of the needle. Gently push the needle straight through the top of the bottle until the entire needle goes in. Then, slowly push down on the plunger to push the air in the syringe into the bottle. You don't want to draw any cloudy insulin into the syringe yet. Remove the syringe from the bottle of cloudy insulin and set the bottle aside. Next, we'll inject air into the clear insulin bottle. I need 10 units of air in the bottle, so first, I'll get 10 units of air into the barrel of the syringe. To do this, simply pull the plunger until the rubber stopper reaches the 10 unit mark. Again, hold the syringe like a pencil and hold the clear insulin bottle on a flat surface with your other hand. Place the needle's point at the center of the bottle, avoiding the metal rim. Gently push the needle straight through the top of the bottle until the entire needle goes in. Then, slowly push down on the plunger to transfer the air in the syringe into the bottle. Now, with the syringe still in the bottle, turn both the insulin bottle and the syringe upside down so the bottle is on top of the syringe. Make sure the needle tip is below the level of the insulin left in the bottle. If the tip is above the insulin level, you'll need to pull the needle out of it. To draw insulin into the syringe, slowly and steadily pull down on the plunger until the end of the black rubber stopper closest to the needle is even with the line on the syringe indicating your dose. In this case, 10 units. It's important to pull slowly, since pulling too fast will create tiny air bubbles in the syringe. These air bubbles take the place of your insulin, which keeps you from getting your full dose. So before removing the needle from the bottle, look for air bubbles in the barrel of the syringe. If you see any air bubbles, slowly push the plunger until all of the clear insulin is back in the bottle. Then redraw the insulin more slowly. Continue to check for air bubbles as you go. Repeat these steps until there are no air bubbles in your syringe. Once you've drawn up your dose of clear insulin without any air bubbles, turn the syringe and the bottle back over and place the bottle on a flat surface. Then, holding the syringe by the barrel, carefully pull the needle straight out of the bottle. Now we're ready to draw the cloudy insulin. Hold the bottle of cloudy insulin upright on a flat surface. Once again, hold the syringe like a pencil with the needle directly above the center of the bottle's rubber top. Push the needle straight through the top of the bottle. Then turn both the bottle and syringe upside down, being careful not to push any clear insulin into the bottle. I already have 10 units of clear insulin in the syringe, so I want to draw an additional 23 units of cloudy insulin. Making sure the needle tip is below the level of the insulin, slowly and steadily pull down on the plunger until the end of the black stopper is even with the marker indicating your total mixed dose. In this example, I'm going to 33 units. Watch that you don't draw the black rubber stopper past your total dose, because you can't push any extra mixed insulin in the syringe back into the bottle. If you were to push the mixture into the bottle, you wouldn't know how much cloudy insulin is actually in future doses drawn from that bottle. So after you've drawn the cloudy insulin, turn the syringe and bottle back over and place the bottle on a flat surface. Holding the syringe by the barrel, carefully pull the needle straight out of the bottle and put the syringe down, being careful not to let the needle touch the surface. Whether you're injecting in the abdomen or thigh, as part of healthy injection practices, it's important to rotate your injection sites. Move the injection down by a finger's width with each injection, and then change to a new site each week. So now, with the second alcohol swab, Clean the small area of skin where you plan to inject. To clean the injection site, start in the middle of the site and then, moving in a circular motion,
This is
clean the
what you guys will
whole
be doing
area.
when you're giving the
To
injection.
reduce any stinging, be sure to let the alcohol on your skin air dry completely before you inject. Next, using your thumb and other finger.
You heard what he says? What are you gonna do when you apply the alcohol swab?
Wait until dry.
Yeah, how are you gonna let it dry?
Air dry.
So don't blow it.
Don't go like this.
Don't go like that. Okay?
Just gently, not too tight, pinch up the area of skin that you just cleaned. Pinching up helps to ensure the needle doesn't hit any muscle and that the insulin is released into the fatty tissue just beneath the skin. Now, in the middle of the pinch, insert the needle straight in. If you're very thin, you might need to inject at a 45-degree angle, but if you're not sure, discuss it with your healthcare professional. When the needle is fully inserted, slowly push in the plunger to deliver the insulin to your body. Then release the pinch as you slowly remove the needle. And that's it. To finish up, put the used syringe and needle in a sharps container, which you can buy at your local pharmacy. Be sure to check with your sanitation company.
Okay, so sharps container. Everyone understood the video? It was okay? Alright. So after you test for your blood glucose, then you'll determine how much insulin the patient needs. You mix your insulin if it needs mixing. If not, you can take it straight from the vial, and then you can go ahead and administer just like how you saw him
So
administer.
for the patients in the nursing home, so if their glucose is high today, it's just according to which day they give them a different dose of insulin?
It's according to the order.
the order?
Yeah, so if the patient's on a sliding scale,
Mhm.
it could be on a sliding scale, the order, the parameters will be in the orders. For
Okay.
instance, if you get a blood sugar for 120, the orders would say, okay, based on 100 to 200, how much units I'm gonna give the patient. Alright, so what we're gonna do, we're gonna check the doctor's orders, right? At all times, we check the doctor's orders. We perform hand hygiene. Can you guys see?
A little bit better.
Better? Perform hand hygiene. Identify who? The
Patient.
patient. We're gonna put clean gloves on always.
Lab. No?
مش في اللاب أعتقد في اللاب.
Yeah, you can see it. Good, better?
Yes.
Okay, put on gloves, clean the patient's hands, right? Because you need a finger to administer this, actually to get the blood. Select the finger to use at the site for the assessments of the blood glucose levels, right? Remove a test strip from the vial that corresponds to the unit and dose, right? Because each test strip it goes according to each machine you're using, glucometer you're using, okay? Not all test strips go to every glucometer. Make sure you have the right one. Turn the unit on, insert the test strip, puncture the patient's finger with the lancet. You know what the lancet is?
Yes, the thing that you use.
Yeah, this is the needle.
No, the on top of it, lancet.
The lancet? Yeah,
Yeah,
it's in
that,
the needle.
yeah.
It normally goes inside.
Goes inside there.
Okay. Where are we? Lancets. Puncture the, insert the test strip, puncture the patient's finger with the lancet. Apply a drop of the blood to the patient's finger, from the patient's finger onto the lancet. Are we going to squeeze and there's something, it's called milk.
No milk.
They call it milking. We don't do that.
Oh.
Because guess what happens? Anybody could take a wild guess when you do that?
Your dirty finger and all.
No.
But I seen them doing that.
So what? Are you gonna do it? It's not everything you see you're gonna mimic, okay?
Right,
Do
but
what you're taught,
it's terrible.
okay? Because guess what happens? You don't know who is doing it. They're seasoned. They're cutting corners, okay? But that's not what you want to do. You want to do the right
Right,
thing,
right.
right? When you're milking, you can get capillaries, all sorts of things more than what you need into that test, the little
Right.
drop of blood, okay? You just want the body to naturally put the blood out. If not, there's something called you hang the patient's hand down where the blood can go to the area, which is the fingers.
Oh, wow.
Okay? Apply gauze to the punctured site. All right, that's after you got your blood drop. Wait for the unit to display the patient's blood glucose reading, right? Dispose of the strip according to the policy. Every hospital, every facility is different. All right, discard the lancet into the sharps containers. Remove your gloves, perform hand hygiene, and document your results. Are we good with that?
Yes.
Okay. Let me minimize this back again. So you remember, this is the same, just a picture of what we just saw in the video, okay? So you're gonna push air into your which vial? Cloudy.
Cloudy.
Uh-huh, then you're gonna move into the
Clear.
clear. Then you're gonna pull up from your clear,
Yeah.
the amount you're supposed to pull up, right?
Yeah.
Make sure you don't pass, well, if you pass the clear, just so happens, it's okay because you only have clear. You can push a little bit back in, right?
What is the reason again to push all the air into the NPH and then
Not
don't
that you
draw it but go to the
Because when you push air into the vial, it gives it like a pressure. So when I'm ready to get the medication comes back easy into my syringe. But because I already have the clear in my syringe, I can't push air in now. You understand?
And what
Yeah.
if you push, like, let's say I'm supposed to take only 12 and I push 14? It's fine,
Air?
right? Air.
That's
It's fine,
okay.
right?
It's okay. Don't put too much because it's gonna come back
Comes
at you.
fast, right? Yeah.
Not necessarily in the syringe, but when you take the syringe out, that pressure.
Oh, it keeps going
They
out.
come out on you.
Oh, see.
Yeah, uh-huh. Because you're putting pressure in there, you're
Right.
causing pressure in this little vial.
Right, right.
So if you take too much cloudy, do you have to discard it, do it over again?
Yeah, pretty much, because it's already
Right.
mixed now.
So
Yeah, so it'll be wasted, yeah.
to be wasting it.
Mm-hmm. Yeah, because once it's mixed, there's nothing you can do. Can't even determine. That's like giving a patient medication and the patient throws up. Can you give the medication again?
You have to ask the doctor.
Yeah, because you don't know how much is consumed. Yeah? Okay, so that concludes the parental meds lab. Let's see if we can go over and practice. Any questions on the materials? No?